I'm very pleased to be providing this October 2023 update on COVID-19 therapeutics. These are my disclosures. In today's program, I'm going to be talking about new data regarding nirmatrelvir or molnupiravir in outpatients with COVID-19, as well as new data on inhaled fluticasone. Let's start by looking at this retrospective analysis of nirmatrelvir or molnupiravir use and severe outcomes from Omicron infections, published by Lin and colleagues in JAMA Network Open this year. This was a cohort study of patients diagnosed with COVID-19 at Cleveland Clinic from April 2022 through February of 2023. This was a period during which the Omicron variants, starting with BA2, were prevalent up to the time of XBB.1.5. The primary outcome of the study was time to death, and the secondary outcome was time to hospitalization or death. In Cox regression models, the hazard ratios were adjusted for demographic factors, socioeconomic status, date of diagnosis, coexisting medical conditions, vaccination status, and previous SARS-CoV-2 infection. Just looking at the disposition of participants, approximately 95,000 individuals were diagnosed at Cleveland Clinic with COVID-19 during the study period. Nearly 20,000 of them failed to meet inclusion criteria, and another 6,500 were excluded for various reasons, leaving them with just under 69,000 patients who were eligible for the study. Now, what they did was to divide these into people who received nirmatrelvir or were eligible for nirmatrelvir, or people who received molnupiravir or were eligible for molnupiravir. So the control group is actually shared. They're not identical because of different exclusion criteria for the two drugs, but it's really a shared control group. Important differences between the treated and untreated individuals in this study were that treated patients tended to be older, were more likely to be white, more likely to have received vaccine boosters, and this was more likely to be their first episode of COVID-19. Looking at the data for the nirmatrelvir part of the study, you can see that people who received no treatment were at substantially greater risk of death than those who were treated. The risk was low, it was 0.01% incidence, but the hazard ratio unadjusted was 0.14, meaning there was about an 85% protection for those who received nirmatrelvir compared to the control. Looking at molnupiravir, similarly, we see that those who did not receive treatment were at substantially higher risk of death than those who received treatment. Here, the effect is not quite as large as with nirmatrelvir, about a 63% reduction in mortality, but still highly significant. We look at the adjusted ratio of death based on different factors. Here again, we see in the adjusted analysis about an 85% protection from nirmatrelvir and about a 75% protection with molnupiravir. The people who were older were clearly at substantially greater risk of death compared to those who were younger, and likewise, people who had vaccination status, had received vaccine boosters, were less likely to die, as were those who had been previously infected. Now, it's interesting to compare this study to a previous cohort study done in California at the Kaiser Permanente group, because here what we're looking at is not risk of death, but what were the factors associated with the use of nirmatrelvir. And what you see is that people who were older age, shown in panel D, and people who had higher comorbidity indices, shown in panel E, or who had received more doses of vaccine in panel F, were much more likely to receive treatment with nirmatrelvir or ritonavir compared to those who lacked these factors. This suggests that health-seeking behavior may be an important confounding factor. And even though in the most recent analysis that I just shared with you, they attempted to adjust for these factors, you still have to worry about residual confounding. The reason to be concerned is because of the very different results seen in this randomized clinical trial of molnupiravir versus usual care in people with COVID-19 who were at increased risk of adverse outcomes in the Panoramic study, an open-label, platform-adaptive, randomized controlled trial. This study done in the UK was multi-center. As I mentioned, it was open label, multi-group perspective, and was what we call a platform adaptive study. The participants had symptomatic confirmed COVID-19 for 5 days or less, and they were randomized 1-to-1 to molnupiravir or usual care. They were stratified for age, above or below 50 years, and by vaccination status. The primary outcome was all-cause hospitalization or death within 28 days of randomization, and here they used Bayesian statistics to do the analysis. One of the secondary outcomes was time to self-reported improvement. If we look at participant disposition here, there were approximately 112, almost 113,000 individuals who were screened. 68,000 plus were put forward for eligibility, but approximately 42,000 ultimately were not enrolled, so that 26,000 were randomized. Nearly 13,000 were randomized to molnupiravir. A similar number were randomized to usual care, and then there was a small number who were randomized to other treatments in this platform study. Looking at the baseline characteristics here, the participants were about 57 years old. There was a female predominance. You can see that most of them had been symptomatic for only 2 days. That was the average time of symptom duration. And they were, as you might expect, given the fact that the study was done in the UK, overwhelmingly white race. Looking at the results, here in the box, you see the Bayesian statistics. So there was really no difference in hospitalizations, no difference in deaths, and the hospitalization or death, which was the secondary outcome, was 1%. And I'm sorry, that was the primary outcome is hospitalization or death. And then the hazard ratio is 1.06, with the Bayesian confidence intervals crossing 1. And remember, as we've talked about in previous programs, in Bayesian statistics, what we're looking at is what was the probability of there being a difference. And the probability that treatment with molnupiravir was superior to usual care was only 0.33, so far off from being statistically significant. This was true even in the subgroup analyses that looked at various factors. We really don't see any differences, except perhaps a suggestion that those who were immunocompromised or those who were in the highest quintile risk for severe outcome were possibly benefit from molnupiravir, but that did not reach statistical significance. So let's talk now about this study of inhaled fluticasone for outpatient treatment of COVID-19, also known as the ACTIV-6 study. This study was just published at the end of September in the New England Journal of Medicine. This was a randomized, double-blind, placebo-controlled trial. Again, it was a platform study conducted in non-hospitalized adults aged 30 or older with at least 2 symptoms of COVID-19 for 7 days or less. The participants were randomized evenly to inhaled fluticasone or placebo for 14 days. The primary outcome was time to sustain recovery. That's different from what we've been talking about before, which was mortality. But a secondary outcome was hospitalization or death within 28 days of randomization, or the need for emergency care, hospitalization, or death. Looking at the baseline characteristics, we can see that the median age was about 45, with the majority of participants being under age 50. There was a predominance of women in the study, about 63%. Of 80% were white. The median BMI was just under 30, with about 40% or so having a BMI over 30, qualifying them as being obese, and about 34% had not received prior SARS-CoV-2 vaccination. Here, looking at the results, this shows both the primary and secondary outcomes through day 28. Once again, using Bayesian statistics, we can see that the estimated difference, or the difference ratio, was essentially 1. And again, remember that in Bayesian statistics, we're looking at what was the probability that there was a significant difference between the treatment arm and the placebo arm, and the p-value here is 0.56, as you see, which shows that this is far from being statistically significant. If we look at duration of symptoms, the mean days of being unwell, again, there was no statistically significant difference. And if we look at hospitalizations or deaths, there were actually no deaths in the study. We see no difference at all. And in the composite endpoint of hospitalization or visit to an emergency room or death, once again, there was no significant difference. The posterior probability is 0.04. Here, that means it's very, very unlikely that there was a difference, as opposed to if we were doing classical statistics where the p-value under 0.05 would be significant. Time to sustained recovery, you can see these curves are completely overlapping, so absolutely no difference. Now, it's important to note that very early on, the principal study done in Great Britain showed a statistically significant difference for inhaled budesonide, another corticosteroid that is given by inhalation. And here, by contrast to the active-6 study, there was a substantial advantage in terms of time to recovery. You can see the probability of superiority was greater than 0.999. So very certain that use of inhaled budesonide provided a benefit. And the same was true in the secondary analyses that looked at hospitalization or death. The probability of superiority was 0.95, with about a 20% reduction in the risk of hospitalization or death at 28 days. There were some important differences between principal and active-6, however. First of all, principal was open label versus active-6 being placebo-controlled, although that alone probably doesn't account for the differences. More importantly, in the principal study, the participants were older. They had to be age 65 years or greater, or be 50 or older with comorbidities, as opposed to the active study where individuals were 30 years or older, and as I showed you, the median age was in the mid-40s. Also, participants in principal were mostly unvaccinated. 90% were unvaccinated, as compared to active, where only a third were unvaccinated. And so these important differences may explain why budesonide showed a benefit, whereas fluticasone did not. I think the bottom line is that inhaled steroids might still be of use in older people and people with severe comorbidities, especially if they've been unvaccinated. But in younger and vaccinated people, there's probably little benefit. Thanks for listening.